physician at Reims University in France, School of Medicine. He is also the director of a stroke unit at Al-Zaur University. Dr. Osman published more than 25 papers in reputed journals. The title of his talk today is the study of first 7 days mortality in acute ischemic stroke among a sample of Egyptian people. Okay, Dr. Osman, if you are ready. Okay, sorry, Anna, is Dr. Osman ready?
Okay, let me check.
Okay.
Yes, I think he's ready.
Okay, we are waiting for him. Okay, Dr. Osman, if you can hear me, I can play your slides if you are experiencing problems with it.
I think Wael one is not right now, not here right now. I think he lost his. There might be some technical issue with him. Anna.
Hello, Mr. Krishna. Usman is facing network issues.
Okay.
With him.
Okay.
I'm trying to call him.
Yeah, yeah.
Okay, so how is everyone enjoying the webinar so far? Did you enjoy the lectures? Okay, did we all lost our connections?
I think Wael one is getting ready. I think.
We can go on a break until Dr. Osman is ready, if you agree. Okay, I think Dr. Osman is. Yeah.
He joined. He joined.
Yeah, he joined.
Thank you. Hello, Dr. Osman, can you hear us? Hello. Hello, Dr. Osman. Hello, Dr. Osman. Can you hear me now?
Hello?
Hello, Osman. Can you hear me now?
Hello?
Hello.
Yes.
Can
I
you hear
start?
me? Yeah, you can start.
Okay. Okay. Let me show my presentation, if possible.
Yeah.
Okay.
Thank you. Nafis, could you please share this PPT?
Yes, of course.
Yeah. Thank you.
Try to connect this.
Okay, Dr. Osman, your slides is ready. Can you see?
Yeah. Okay. Okay. Thank you. Firstly, I want to thank all my colleague for attending this conference, and this is the second time for me to attend. So I hope to attend the next, inshallah. Now we will talk about the study of the first 7 days mortality in acute ischemic stroke among a sample of Egyptian patients. My name is Wael Osman, Professor of Neurology, Al-Azhar University. Next. Next, please. Previous one. No. Previous.
Okay. This one?
No, please. Previous one. Previous. Okay.
This?
Yes. These are colleagues who share my paper. Dr. Said Zayat, professors of neurology at Al-Azhar School of Medicine. Dr. Muhammad Fuad, professors of radio diagnosis. Dr. Wael Refat, professors of clinical pathology. And me, Dr. Sabri Muhammad Fathi, professors of neurology, and Ibrahim El-Aisawi. Next. Stroke is a clinical syndrome of rapidly developing symptoms and signs of focal loss of the cerebral function with no apparent cause rather than the vascular origin, lasting more than 24 hours. It's very important, okay? Or may lead to the death before this. This is the definition by WHO 2010. 1 in the 5 stroke are fatal. Okay, stroke causes about 7% of this in men and 10% of this in women. Next, stroke is the second cause of this and over the third cause of this occur in Arab countries. The annual incidence of stroke in Upper Egypt, my country, was 1.8 over 1,000. Mortality after stroke in Egyptian patient was found to be 90.9% ischemic stroke, continued 64.5%, while hemorrhagic stroke continued about 35% of stroke in Egypt. Okay. Next.
This meeting is being recorded.
Leave this. A wide variety factor of stroke prognosis and mortality
Okay, I think we lost Dr. Osman, or is it just me? Can anyone else hear Dr. Osman?
I think he's here. I think there's a problem with his network.
Are you experiencing connection loss, Mr. Karishna, or is it just me?
No. We lost his connection. Osman. There's a problem from him.
He's here still, but I think he lost his connection.
Dr. Osman, can you hear me? Hello, Dr. Osman. Hello.
Yeah. I'm leave this. Do you hear me?
Yes, we can hear you. Please continue.
Okay. I'm sorry for this interruption. Okay.
It's okay.
Okay. A wide variety of factors affect the stroke prognosis and mortality, including age, stroke severity, and stroke mechanism, infarct location. And the regard for infarct location is very important due to the brainstem affection and large infarction can affect the conscious level and the prognosis of this stroke. Also, comorbidity condition. If the patient have comorbidity like diabetes, hypertension, ischemic heart disease, or AF, or like that, can affect the prognosis of stroke. Clinical finding also, and the related complication at the recumbency and the prolonged stay in the hospital. In addition to the intervention like thrombolysis or mechanical thrombectomy, okay? Stroke unit care and rehabilitation can play a major role in the outcome of ischemic stroke. There are frequent causes of death in ischemic stroke. This factor may reflect the direct effect of stroke, as severe brain injury leads to damage parts of the brain, Next. Next, please. That control breathing and functioning of the major organs, such as the heart. Okay, brain edema, which leading to increase the intracranial pressure and subsequent herniation of the brain and causing this, as well as Stroke in the brainstem may affect the vital and cardiac respiratory function. Additionally, there are indirect complications of stroke leading to death as the pulmonary embolism due to prolonged recumbency, aspiration pneumonia also, and heart attack. Knowledge of important factors that affect the stroke prognosis is necessary for clinician or stroke physician to make a prediction for individual patient, to provide rational approach to patient management, and to help the patient and family to understand the course of the disease. Next. Aim of this work to identify the clinical, laboratory, and radiological predictor factors of 7 days mortality after an acute ischemic stroke, and to analyze the medical and neurological complication that will cause death. Subject and methods. The study was carried on 100 patients with the first-time ischemic stroke. Within the first 24 hours of their symptoms, attending to Al-Azhar University Hospital during the period between December to June 2015. All patients were subjected to. All patients were closely followed up to monitor progress of this case. The endpoint was mortality or survival at 7 days from the stroke onset. The key variables depend upon clinical, laboratory, radiological assessment of all patients. Just next, please. Clinical assessment including full general and neurological history, general and neurological examination including assessment of stroke severity by using National Institute of Health Stroke Scale, which contain 42 items. Okay, we used the Charlson Comorbidity Index to qualify patient comorbidities. Summary of the score based on the presence or absence of 17 medical condition as 17 medical condition. A score of 0 indicate that no comorbidities are present, and the higher score indicate greater burden of comorbidity. On this base of the Charlson Comorbidity Index, patient will categorize have 0 or 1 or 2 or 3 or more comorbidities. P, laboratory assessment. Laboratory investigation including renal function, CPC, and liver function, ESR, lipid profile. Radiological assessment, CT brain or MRI imaging. Next. Result of this study, at the regard of age and gender, there was no significant difference between survivor and non-survivor group as regard to gender and age. At the regard risk factors of ischemic stroke, hypertension, smoking, AF, and ischemic heart disease, there was a significant difference between different groups as regard of hypertension and AF. Next. As regard the family history of ischemic stroke, we classify the patient to patient have a negative family history and patient have positive family history. We find that there is no significant difference between both groups. Next. As the regard of Charlson Comorbidity Index, patient 0 to 1, patient 2, patient more than 3. There is no significant difference between different groups as the regard of Charlson Comorbidity Index. As the regard of stroke severity, patients have a score of National Institute of Health Stroke Scale less than 15 and more than 15. Less than 15, there was no significant difference between both groups. Next. As a regard of conscious level, we classify the patient firstly alert, second drowsy to stupor, or semi-coma and coma. There was a significant difference between different groups as the regard of conscious level. All of patients have a conscious level deterioration, like drowsiness and stupor and semi-coma or coma, more affected than the patient who alert. Next. As regards early neurological deterioration after ischemic stroke, early neurological deterioration, we classify to both groups, negative or positive. There was a significant difference between both groups as a regard of early neurological deterioration after ischemic stroke. Next. As a regard early onset seizure after ischemic stroke, some of patients have a negative but positive seizure after stroke, and some of them have no manifestation of seizure after ischemic stroke. But we find that there was no difference between both groups as a regard of early onset seizure after ischemic stroke. As a regard of presence of medical complication of stroke as a fever, there was no significant difference between patient have a positive fever or patient have a negative fever. As regard a medical complication of stroke as pneumonia and DVT, we have a patient of pneumonia and DVT. Okay, there is no difference between different groups as regard of pneumonia and DVT. As regard of stroke location and the size of stroke or infarct area, this is very important one. But we find that there was no significant difference between the different groups as regard of stroke location and the size of stroke. Conclusion. The study indicated that identification of prediction of major acute ischemic stroke during hospitalization is necessary for clinician to make a prediction of individual patient to reduce the rate of death after stroke, improve the process and the quality of provide rationale approach to patient and help him and his family to understand the course of the disease. Initial stroke severity, neurological deterioration after admission, hypertension, atrial fibrillation, fever at the onset, all are associated with stroke case fatality at 7 days. Recommendation, we recommend that further clinical studies with a large sample size are necessary. Further clinical studies with the different variables. Third, early detection of factors affect stroke prognosis and mortality as stroke severity, stroke mechanism, infarct area, location, comorbidity, and clinical findings are related complication of stroke. In addition to early intervention by thrombolysis or mechanical thrombectomy, also stroke unit care, early rehabilitation, and after recovery can play a major role in outcome of ischemic stroke. Last one is the early health education for early detection of stroke. It's very important. In different media, this can improve the outcome of stroke. Thank you very much. Any question from our colleague?
Does anyone has any questions? Thank you a lot, Dr. Osman.
Thank you.
Thank you, Dr. Osman.
Thank you very much.
Okay, if anyone doesn't have